Good afternoon and welcome to today's OR Today webinar. Today we are joined by Kristy Warren, Director of Clinical Resources at Encompass Group. Kristy joined the Encompass team in July 2016 and her current role allows her to bring her education, experience, leadership and skills to the development and manufacturing side where her focus is on best practices, innovation, design, development, collaboration, training and education. So OR Today would like to thank our sponsor, Encompass Group. Encompass is one of the world's leading manufacturers and marketers of healthcare textiles, healthcare apparel, patient warming and therapeutic support products for the healthcare industry. Encompass believes that every patient, resident, caregiver and family member should feel safe and comfortable in today's healthcare environments. The way Encompass enhances the healthcare experience is by developing innovative products that are reliably delivered and cost-effective for all providers. The markets they serve include acute care, long-term care, senior care, retail healthcare apparel, hospitality and government operations. So for more information, please visit encompassgroup.com. Today's webinar is eligible for one continuing education hour from the California Board of Registered Nurses. So you can obtain your certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. Now, if you have any questions, you can reach us at webinar@mdpublishing.com. Now, just a quick reminder that OR Today is pleased to support Periop Connect, which will take place October the 11th and 12th at the Omni New Haven Hotel at Yale, New Haven, Connecticut. So for more information and details, please visit periopconnect.com. Let's kick off today's webinar by giving away one of our OR Today webinar lunch bags to the attendee that can tell me the answer to the following trivia question. March is Colon Cancer Awareness Month, so what colour ribbon has become the universal symbol of colon cancer? Answer now using the question feature on your dashboard and I'll reveal the answer at the end of the webinar. We'll be having a live Q&A at the end of today's presentation, so please submit your questions anytime using the questions feature on your webinar dashboard. Now, as I mentioned earlier, our presenter today is Kristy Warren.
Good afternoon. Welcome, everyone. Thank you so much for attending the Start Warm, Stay Warm. Every minute counts. I truly appreciate the opportunity to present to you all today. The objectives for the messaging that we'll be receiving will be to learn more about the impact of surgical site infections, the continuing prevalence of hypothermia, the understanding of the role of the perioperative team in maintaining normothermia and explaining how heat is lost. We'll also review some typical warming methods and how to combine warming methods to achieve optimal outcomes. So as I prepared for this webinar, I used a number of articles to do some research, and what I realized is the messaging hasn't changed for the past 10 to 15 years. In 2006, articles were stating perioperative nurses can help prevent unplanned hypothermia by enacting, supporting, and formalizing policy in the perioperative arena. And now, today, we're still experiencing unplanned hypothermia at high levels, with up to 70% of surgical procedures experiencing inadvertent hypothermia, generally defined as the core body temperature lower than 36 degrees Celsius. So we've worked diligently to minimize the risks, yet there is still prevalence and we are still missing something. Let's start by looking at the impact of surgical site infections. This slide represents efforts that have been made to reduce hospital-acquired conditions. Unfortunately, despite our best efforts in surgical site infections, they continue to still be on the rise. We've made several advances to help reduce surgical site infections over the years. We have better infection control practices with CHG bathing, our surgical preps, our use of PPE. We have better improved operating ventilation with our HEPA filters and our ultra clean laminar airflows. We have better sterilization methods now. Our barriers, our surgical techniques have changed with less open approach to those surgeries and more advancements with laparoscopic procedures and robotics. And we also have more availability to the antimicrobial prophylaxis. However, with all the advances, our surgical site infections remain a substantial cause of morbidity and prolonged hospitalization and subsequently death. According to the CDC, approximately 157,500 individuals are affected by surgical site infections each year. And these surgical site infections are associated with a mortality rate of 3%. 75% of those surgical site infection deaths are a direct result of the surgical site infection versus a secondary condition. And surgical site infection is the most costly hospital-acquired infection with an estimated annual cost of $3.3 billion. It's associated with nearly 1 million additional inpatient stays annually. And the number of surgical operations in the United States continues to rise, with the cases being more outpatient focused than inpatient, as you can see on the graph here. We have some common risks and variables for surgical site infections. Some of these include the procedure-related variables with what the type of procedure is, if the procedure is invasive, if it's planned or unplanned, and the length of the procedure. And some facility-related variables could include the cleaning practices, the amount of traffic, and the ventilation in the OR. And for preoperative environment variables, we have the skin preps, the antibiotics, and glycemic control. And then intraoperatively, we're looking at variables such as scrub techniques, proper attire, and hypothermia management. With several procedures now lasting less than 1 hour, it's often not possible to regain that temperature balance, and the patient's generally delivered to the PACU hypothermic, requiring additional warming interventions and nursing time. And for this reason, we must strive to maintain the patient's body temperature by minimizing any cutaneous heat loss to ensure that they maintain normothermia throughout their perioperative journey. So what is unplanned hypothermia? Unplanned hypothermia is recognized as an unintentional occurrence of a patient's core temperature that drops below 36 degrees Celsius in the perioperative setting. This unplanned hypothermia presents a serious risk to patients undergoing surgery and has been well documented to be a contributing cause to adverse complications. According to AORN's guideline on prevention of hypothermia, hypothermia may cause multiple complications such as adverse myocardial outcomes, alternating metabolism of anesthetics and other medications, thermal discomfort, an increase of length of stay in the PACU, and shivering. And the surgical site infection risk also increases with hypothermia as a result of a reduced skin oxygen tension with diminished oxygen delivery to those surgical sites, subcutaneous vasoconstriction and impairment of the immune function, and resistance to surgical wound infection. On a study of more than 58,000 surgical patients at Cleveland Clinic, it revealed despite the use of forced air warming, 64% of these patients were hypothermic 45 minutes after induction. And this is an exceptionally large number of patients to be impacted, despite active warming protocols utilizing forced air, and is a reminder that many patients remain at risk and they may need improved strategies to keep them warm. In an effort to prevent or mitigate the risks of unplanned hypothermia, patient warming management has adopted a standard of care of most acute care settings. And these standards look to minimize cutaneous heat loss and help reduce the unplanned hypothermia risk. Patient warming management applies external warming methods to maintain normothermia perioperatively. And although patient warming methods are beneficial in reducing the unplanned hypothermia and associated complications, certain patient warming devices may fall short of temperature targets, and others may have the potential to introduce collateral risks. And these risks may include surgical site infection or thermal injury. So innovation and new design adoption in acute active warming has the potential to further reduce or mitigate the risks of that unplanned hypothermia. So for the mechanism of heat loss, there are 4 mechanisms that we lose heat for the perioperative patient. The largest sources are radiation and convection. And both of these occur more rapidly when the skin surface is unprotected. And this affects all patients, especially those patients that are undergoing shorter procedures when rewarming time may not be available. So once the patient moves to the intraoperative area, it is imperative that we protect the patient by maximizing that skin surface coverage to prevent any additional heat loss. And according to the Cleveland Clinic, the roughly 90% of the metabolic heat is lost through the skin surface. With unplanned perioperative hypothermia, it reflects the body into 2 thermal compartments. The core, which is made up of the chest, the abdomen, the pelvis, and the head, and the periphery, which is the extremities and the skin surface. And this is important to keep in mind when choosing the appropriate warming blanket for the type of surgical procedure. And just a reminder, the body's core generates the heat and its surface is the dissipator of the heat. Following the induction of general anesthesia, the body temperature declines in 3 different phases. In phase 1, which usually occurs during the first 30 minutes, has the greatest decline, which is representative of 1 degree Celsius to 1.5 degrees Celsius on average, which would be 1.8 degrees Fahrenheit or 2.7 degrees Fahrenheit loss. Vasodilation allows the redistribution of the body heat from the core to the peripheral skin. And this is what we call redistribution temperature drop, or RTD. And what happens with this is, if you're looking at the screen, you see the core on the patient on the left is 37 degrees Celsius, and on the right is 36. The periphery of that patient that's vasoconstricted on the left, this is before anesthesia. The peripheral compartments are 31 degrees to 35 degrees Celsius, and that's on average, that's normal. When we inject the anesthesia, the patient then becomes vasodilated, allowing that warm core blood to now rush into those areas of the periphery, which then mixes with that cooler peripheral blood. And when that happens, that peripheral blood is then brought back up to the core, and it's a cycle of warm blood to cool blood to warm blood to cool blood, and it eventually drops the patient's body temperature. The vasodilation is where the arterioles will dilate or enlarge so that more blood enters the skin capillaries, and that's when the heat is lost. In phase 2, it's approximately after 1 hour, and this is when the heat is lost from the body, and that's when it's the heat lost exceeds the heat production, so we can no longer keep up with that production. And then in phase 3, the heat loss is matched by the heat production, and thermoregulated vasoconstriction commences to function. So pre-warming the patient and ensuring that the extremities are warm, specifically the legs, will help to reduce or lessen the risk of that redistribution temperature drop. In the PACU area, or the postoperative area, as the anesthetic-induced peripheral vasodilation dissipates, the thermoregulatory vasoconstriction starts to commence. Vasoconstriction is when the arterioles get smaller to reduce the blood going to the skin in an effort to keep the core warm. The heat is then transferred from the periphery to the central core tissues, and that is significantly impaired by the vasoconstriction. At this stage, applying warming to the skin is not as effective as it is during surgery because it's going to take longer to rewarm the patient due to that vasoconstriction. So it's easier to maintain the intraoperative normothermia than to rewarm the patients postoperatively. And that's why we like to say start warm, stay warm. If we can start them warm and keep them warm, then they generally will come out warm and we can continue to keep them normothermic. Some other contributing factors, the environment. The OR should generally be warmed to 21 degrees Celsius or 69.8 degrees Fahrenheit or warmer. The anesthesia type plays a role. If the patient has a low BMI, that will also be a contributing factor. Comorbidities, age, fluids, if they're getting irrigation fluids or cold blood, exposure, and then also surgical prepping time. When we look at evidence-based practice, the evidence-based practice models give us guidelines to help manage or take a proactive approach to the hypothermia management. And guidelines for prevention of hypothermia can include selecting a method of warming based on the planned procedure, the patient positioning, where those IV sites are, and warming constraints. And methods include active warming, passive warming, or a combination of both. And AORN actually supports a combination of both methods to be the most effective approach to the patient warming. Normalizing the patient's core temperature before surgery, start warm, stay warm, is another evidence-based practice. Using active warming according to the manufacturer's instructions. So some of the risks associated with, for example, forced air warming could include thermal burns or injury to the improper use or sticking warming hoses under the blankets or things like that. So make sure that you're always following the manufacturer's instructions. Administering warm IV fluids is another best practice based on the patient's needs. And warming the irrigation fluids can also help. The surgical suite to 21 degrees Celsius or 69.8 degrees Fahrenheit. And then pre-warm the patients 20 to 30 minutes prior to surgery. Perioperatively, the largest possible area of the body surface should be thermally insulated, so covering as much as possible during the procedure and throughout their perioperative journey. And then also warming anesthesia gases is another best practice, initiating rewarming interventions based on the patient's temperature and their arrival to the PACU, and then using a consistent method of temperature monitoring, making sure that your temperature gauges are accurate when you're taking those patients' temperatures. Some of the warming methods. There are two forms of warming. There's active and passive warming. The passive warming works by the patient rewarming on their own using their endogenous heat production, and that's where that heat is reflected back to the patient. And the active is the application of exogenous heat to the body externally. The passive warming usually contains cotton blankets, reflective warming, socks, head covering, surgical drapes, plastic sheeting. And the cotton blankets are a passive therapy, and they've been a staple in the OR for years, and that's why I placed them at the top of the diagram. But they're still widely used and can provide a sense of security and comfort to the perioperative patient, but they don't last very long as far as the heat retention. And they cool rather quickly, leading to a high utilization for patients. And there is also a cost associated with these cotton blankets for reprocessing, so they can become quite costly with an average around $1 per blanket. And typically adding one patient's perioperative journey from start to finish, we're typically using around 10 8 to 10 to 12 blankets per patient, so it could be quite costly. And unfortunately, our efforts to warm and provide the comfort may also be contributing to another problem. And according to an article written by Moss et al., sterile lint and fibers in the OR serve as a transport mechanism for opportunistic bacteria, which can potentially be carried on air currents and settle into those open wounds and those sterile fields. So they could potentially deposit lint fibers. And when deposited inside of a surgical wound, these particles can adversely affect the healing process and lead to adverse patient outcomes. And the author goes on to state that removing the lint in the OR is imperative in today's healthcare environment. So I have the reflective warming on here. This is another passive warming modality, which combines the function of the traditional linen with intrinsic warming and insulating properties that start to work as soon as they're applied, and they can complement those active warming products or be used in combination. They can also help with that pre-warming of the patient in that preoperative area. The active warming measures, the forced air warming, there's circulating water, radiant warmers. There's also conductive warming, and there's a new carbon fiber technology warming, and then electric warming blankets. The active warming is the most common measure used intraoperatively. However, according to Roth, it's difficult to demonstrate an increase in the core temperature from our active warming techniques with forced air warming until at least 30 minutes after the anesthesia or the time has elapsed. So again, adding additional modalities for that patient warming. So what can we do? According to an article by Sherry Burns, Keeping Patients Warm Throughout Surgery, she states that the secret to making sure that your patient stays warm is to combine measures to maintain the body temperature from the time that the patient enters your facility through discharge. When assessing risk for the development of unplanned hypothermia, we need to remember that all the patients are at risk and they need to be protected. We should challenge our historical protocols and evaluate our patient population to determine what the best method or combination of method is that fits their particular needs. Now let's look at the patient's perioperative journey and discuss how we can maintain normothermia from start to finish. So unattended or inadvertent hypothermia has been called the most frequent preventable complication of surgery with all patients at risk, regardless of their age, gender, and length of surgery. And evidence-based studies demonstrate most patients arrive in the pre-op area normothermic, yet we're missing opportunities to prevent cutaneous heat loss. So by the time they get to that PACU area, now they're hypothermic. The preoperative patient journey has 4 distinctive areas that can contribute to that hypothermia before the procedure even begins. So from the admission in the waiting room area, so cold temperatures, they start to begin to lower the patient's body temperature here. So they're coming in from a warmer environment and they come into an AC or a cooler environment, they could start to drop their temperatures in this area. The pre-op area, we typically undress the patients, which creates that ability for them to lose that heat. There's cooler temperatures here. We're starting IV lines, which room temperature IV fluids may be going in. We're doing prepping, marking the surgical sites or locations. We have huge opportunity for heat loss in this area in the pre-op environment. And then the transport, we're transporting the patient with minimal covering through cold hallways with limited warming interventions. And some departments or some ORs are designed where the OR suites are quite a distance from those preoperative suites. So there could be a lengthy ride in that transport to get to the OR, which could also contribute to their heat loss. And then when we get into the OR suite, we have frigid room temperatures, the pre-op, the positioning, we're prepping the patient, exposing the patient, and that's where we have another opportunity for significant heat loss in these areas. As previously mentioned, most patients will arrive to the pre-op normothermic, but if we allow them to arrive to the OR cold, now we're playing a game of catch-up. The AORN guideline of prevention of unplanned hypothermia states that the majority of the evidence establishes the benefit of preoperative patient warming. And for this reason, early implementation of warming strategies would improve the patient comfort perioperatively. It would help to effectively bank heat and deliver the patients warm to the OR while minimizing the risk of that unplanned hypothermia. This is consistent with ASPAN's perioperative normothermia guideline, which recommends implementing passive thermal care measures preoperatively. And passive thermal care measures include the application of warmed cotton blankets, reflective blankets, socks, and head coverings, and limiting that skin exposure to those lower ambient room temperatures. And the guideline goes on to suggest that you can continue these measures perioperatively and limit the skin surface exposure and implement active warming in addition to passive thermal care when necessary. The ERAS protocol was developed to help enhance the recovery after surgery, and the Johns Hopkins Armstrong Institute for Patient Safety and Quality, in collaboration with the American College of Surgeons, has been awarded nearly $4 million contract with the option of $12 million over 3 years for a total of $16 million from the Agency for Healthcare Research and Quality, or AHRQ, to improve the outcomes and experiences of surgical patients across the United States. And this project enabled more than 750 hospitals to implement the ERAS protocols, which have been shown to reduce complications, decrease lengths of stay, and boost the patient experience. And they were divided into 4 cohorts, each which lasted about 12 months. And the hospitals were able to pick the cohort in which they participated. The first cohort focused on colorectal surgery, which started in July of 2017. And the second cohort focused on colorectal hip fracture and comprehensive joint replacement surgery, which started in March of 2019. And as you can see, the reported results are remarkable. Their length of stay reduced by 1.5 days. The cost of the surgical procedures dropped by $1,500. The patient complications decreased, and there was 50% decrease in surgical site infections. This is just an example of what the elements of an ERAS program looks like. They're beneficial to have shown to improve the outcomes, and the key elements of the ERAS include the patient and family education, patient optimization prior to admission, minimal fasting that includes a carbohydrate beverage 2 hours before anesthesia, multimodal analgesia with appropriate use of opioids when indicated, and to return to a normal diet and activities the day of surgery and returning home. And in this example, the pre-warming is recommended in pre-op along with active warming intraoperatively. So we look at how to keep the patients warm, and we look at the rule of 9s. And this rule of 9s was typically used for burn patients, but it helps to divide the body's skin surface into sections, each with a value relative to the total body surface area. So it can be useful when determining how to optimize the skin surface coverage. And the updated AORN guideline for preventative and unplanned patient hypothermia identifies considerations for selecting a warming method that includes the planned procedure, the patient positioning, and warming equipment constraints that could limit the access to the surgical site. So combining measures such as passive and active warming can significantly improve the skin surface coverage. So I'll give you a typical example. A typical upper body blanket application addresses approximately 27% of the patient's skin surface, which would be the chest, the abdomen, and the arms. If we're only applying an upper body blanket to this patient, an active warming blanket, we're only addressing 27% of that patient's warming needs. If we were to add additional warming, passive warming, such as a reflective warming cap and a lower body blanket or leggings, we could additionally cover 45% of the skin surface. And then combined with these passive and active warming, we could maximize the skin surface to 72% coverage versus 27% coverage. And then remember, the cold extremities, cold blood to the core, so we want to make sure that we're covering, if the extremities are not being operated on, we want to make sure that we're always covering those areas so that we can preserve as much heat as possible. So what can we do? Nurses are influencers, and we can work together to ensure that all phases, meaning the pre-op, the intra-op, and the PACU areas, are working together for this common goal. The room temperature, this starts in the waiting room. The room temperature affects the patient throughout the perioperative experience. The challenges with the surgeon and staff preferences are real, yet we are seeing surgeons and facilities throughout the country that are actually taking steps to warm up their ORs. And this one intervention can dramatically impact the outcomes of these patients. And in my travels, most of the facilities are doing a good job of warming irrigation fluids, but starting a room temperature IV contributes to cooling. Facilities that start IVs with warm fluids are taking a proactive measure in maintaining the patient's temperature. And cutaneous heat loss, as you know, has been the theme in this presentation. This starts in pre-op when the patient's changed into a gown. We need to implement passive warming immediately to pre-warm and send the patients to the OR as warm as possible, or even a bit warmer than when they entered the pre-op area, to minimize the exposure to those cool room temperatures and keeping them covered as much as possible. And in the OR, we all know that positioning and prepping are huge contributors to cutaneous heat loss. So do your best to cover the patient or keep them covered as much as possible during the prepping and positioning, and then possibly using a combination of methods, and only expose those areas that are needed for minimal amounts of time for prepping. And be aware that tourniquets or sequential compression devices release cool peripheral blood into the core. That could also contribute to that potential hypothermia rush. And in the PACU, maintaining normothermia or implementing passive and active if indicated. The goal, as indicated by the title of this program, Start Warm, Stay Warm. So what role will you play? In summary, the shift to the ambulatory surgery is continuing to be our future. Our cases are getting shorter. We have less time to rewarm our patients. So it's important that we remember that all patients are at risk. And in spite of our efforts with hypothermia prevention, experts agree that it continues to be a significant issue for our patients. The ERAS program, this considers patient warming to be maintained perioperatively for normothermia, and it considers it to be a key component in accelerating the patient's recovery. And then maximizing the coverage of the skin at all times is essential to minimize that cutaneous heat loss. Hypothermia is a serious issue, and once the physiological cascade has begun or has been triggered, our patients are at a greater risk. Aggressive measures to rewarm the patients and playing catch-up is not where we want to be. And finally, the combination of methods from start to finish is the best strategy to prevent cutaneous heat loss and to keep our patients warm, because every minute counts.
Okay, thanks so much, Kristy. We've got a couple of questions come in, so are you all ready for your Q&A?
Hi, yes, thank you, Linda.
Okay, right. The first question that has popped up is there a big difference between cotton blankets and reflective blankets in terms of warming passively?
That's a great question. So with the passive warming blankets, the reflective blankets actually use that body's endogenous heat to reflect the body heat back to the patient. And it also traps that heat in there to not allow that heat to escape. So when you have that reflective warming blanket on, it actually does that heat retention and reflection. Whereas the cotton blankets, they're porous in their construction, so they allow that heat to evaporate or escape from the material as the passive warming. And the additional use of cotton blankets doesn't add a whole lot of benefit other than the weight. The cotton blankets typically last around 4 minutes if you're bringing them from a blanket warmer, the heat retention on those blankets. So adding the additional cotton blankets doesn't warm as effectively or continue to warm the patient as well as the passive warming with the reflective technology.
Okay, keeping on the subject of reflective blankets, can the reflective blankets be used to pre-warm effectively?
Yes, in fact, several facilities have chosen to use this as part of their protocol. They'll add the caps or the blankets or leggings blankets, depending on what their surgical procedures are. And they actually add these as the protocol for their pre-warming in the pre-op areas to have that one blanket that travels through from the start to finish. And it also helps them to reduce their expenses, their cost, additional lenting in the OR, as we mentioned. So different protocols require them, but the blankets, the reflective blankets, are something that are being used widely across the nation as far as the protocols for that proactive warming.
Okay, here's one. Some of our surgeons refuse to use certain types of active warming. How can we help to manage the temperatures of these patients?
Great question. And I have seen that. This is something that, you know, as the messaging from this webinar, the start warm, stay warm, and really focusing on keeping and maintaining that normothermia from the beginning will help in this area. There's also other additional methods that can be done. So the passive warming in the pre-op area, of course, we talked about that redistribution temperature drop. We want to make sure that we're warming those extremities and keeping them warm and maintaining that warmth before they go back to the OR, especially if they're refusing to use active warming in the OR setting. But other methods such as warming those OR suites to the guidelines, the AORN guidelines of the 68-degree Fahrenheit to 75-degree Fahrenheit. We can also warm those IV fluids. We can work on that irrigation, warming of the irrigation fluids, and then making sure that we're not exposing any areas that are non-operative. So your extremities or areas that we're not having surgery on, we want to make sure that those are covered, especially during the procedure, passively warming them if we don't have that active warming protocol.
Okay. Have you seen any benefits with implementation of normothermia bundles, combining multiple interventions, for example, active warming, active fluid warming of IV solutions and irrigations, active warming of gases, body temperature monitoring, etc.?
Yes, and there's a lot of research out there that shows the benefits of using those bundles. There's and the ERAS protocol is one of those, and that's why we mentioned it. That's something to be explored. The AORN guidelines and the ASPAN guidelines, they all recommend these bundles. So there's a lot of research that's been done on these bundles that can help to improve maintaining that normothermia, as well as reducing the risk for surgical site infections.
Okay, just leading on from that, an attendee has said the revised ARN guideline now provides a sample Normothermia bundle for facilities. So that's just a FYI.
Yes.
Only if
Yes,
it's interested.
absolutely. Check the resources. There are lots of resources out there. The AORN is just one of those guidelines that we like to refer to, but absolutely check your resources.
Perfect. Okay, another question here is, some patients request cooler air versus warmer air. Does this add to the reduce of heat loss, especially since the warming units had that as a setting?
That's typically something that we would see in like a pre-op setting. And some patients, they have that, some patients actually have that, I want to say hyperthermia response, but they get those hot flashes or they want the cooler air on them in the pre-op setting. Really the efforts are to maintain the normothermia as much as possible. And if they're normothermic and obviously you don't want to make them uncomfortable, make them comfortable. But once they get back to that OR setting and we're prepping for that general anesthesia, we want to make sure that we are doing our best effort to try to prevent any kind of hypothermic outcome. So that's the opportunity where we can jump in and start adding warming modalities.
Okay, so another one here is, how do you promote warming in ambulatory surgery cases which are mainly short cases?
I think the passive warming works wonderful. The active warming may be one that we might not even need during that time if we do a good job of pre-warming the patient. So if we start that pre-warming initiative right in the pre-op setting, and I'll use that reflective blanket as an example, we can start to pre-warm. We send the patient back generally warmer than they came in with that.
Not sure if I've lost you, Kristy. Okay, I'm not sure if everybody heard what Kristy was saying. We seem to have a little bit of a technical issue with the audio. Just checking, Kristy, can you hear me? Okay, looks like we may have a slight audio problem. Okay. I'm presuming everybody can hear me. Okay, perfect. Well, we seem to have, unfortunately, lost Kristy's audio. Unless, Kristy, do you want to unmute and see if we can hear you again? Otherwise, I will wrap up. Okay. Okay, I'm to apologize to the attendees. Fortunately, we are coming to the end of the webinar. We have a technical issue with Kristy. So I will go ahead and wrap up. If you do have any further questions for Kristy, please drop me a line at webinar@mdpublishing.com and I will forward them to you. So thank you, Kristy, for your time today and for such an informative presentation. Please visit Encompass's website, encompassgroup.com, to learn more about the products they provide to the industry. Now, as promised, the answer to today's trivia question is dark blue. So congratulations to our winner, Michelle Crawford in Pennsylvania. Now, just a quick reminder that you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit ortodaywebinars.live for more details of all our upcoming webinars and complimentary registration. Now, just a quick reminder that if you've missed any of our past OR Today webinars, including any by Encompass, you are able to view them on our website, ortodaywebinars.live. Thank you for your time today, and I hope you all enjoy the rest of your day.